Thank you very, very much indeed. It's a real privilege to be invited here at this very interesting meeting with, I'm sure, a lot of new ideas. So, since I submitted my draft that you have in your hands, I changed a little bit the structure of my talk. And actually, I thought I could refer to the 4 stages in our prevention of major complications. It's just a concept. It's not something which is very strict, very precise. But I think that all our discussions start from a concept of patient trajectory in the hospital in particular, and improved interactions between departments. The patient can go through the emergency room to the ward, then to the ICU, to the ward, maybe back to the ICU. In the past, we had silos. This is my emergency room. This is my ICU. This is my ward. And really, we helped to work together and also to collect data together, already from the ambulance. I like to speak about the future of emergency medicine and consider all the things we can already do in the ambulance. Collect blood, start to send data to the hospital, EKG, echocardiography, and we can already record a number of variables in the ambulance. And this could be combined, followed up with other data collected in the hospital. We can speak a lot about the interaction between emergency medicine and critical care medicine, but we need to consider the entire hospital with its complexity. And we are all intertwined. We should all work together. And this is not only in case of cardiac arrest, as it was in the past, with the so-called code blue. There is a serious complication. The patient comes in the ICU, and then there is a post-anoxic brain damage. No. We need to act earlier so that the patient will be less critically ill when he or she arrives in the ICU. The length of stay in the ICU will be shorter, and hopefully things will go well. Patients do not deteriorate suddenly. We just suddenly realize. And indeed, we heard from Dr. Davita all the benefit from how do you call it? I think we have a problem in terms, and I spoke about it several times with the late Rinaldo Bellomo. I said, you know, we need to agree on an abbreviation because we use abbreviations for everything. And MedTeam is not so good because it's not necessarily only medical emergency team. And RRT, that Rinaldo liked very much, to me, it's more renal replacement therapy. So no, I don't call it a rapid response team. And so I think that what we heard here, rapid response team, is a better abbreviation. So it's not only in case of cardiac arrest, but much earlier that we need to intervene. Graphically, over time, the patient, after surgery, for instance, may have an inflammatory reaction, maybe a little bit of fever, but if the situation gets more complex, more life-threatening, of course we need to act, but we would like to act earlier. So maybe just physiotherapy will help. Maybe just tracheal aspirations, non-invasive ventilation. Or maybe we need to re-explore the abdomen, do an abdominal CT scan, or repeat the blood cultures, or ask for an infectious disease consult. We need to act before the situation becomes very complex and life-threatening. And so I took this excellent paper from Dr. Jones and Davita and Bellomo, just to indeed recall that initially the METS team or the rapid response team, rapid response systems, would be called by nurses. And indeed, Ken Hillman came to Brussels several times to say, that's the kind of text we put on the ward saying, you know, you can call us if there is anything. I have my concerns because, of course, nurses are really excellent, but we don't want to replace the doctors on the floor. So in our hospital, we decided to, of course, take some distance from the phone call, but to immediately go to the floor when there is a call coming really from a doctor. So I like the American concept of intensive care unit and critical care medicine. That's what it is. It's ICU without borders in our institution, but systems can be different here and there. We need to call the extension 4444, and there is a doctor ready to go on the floor. We also have a physiotherapist who can go on the floor during the night. It's a separate call. In some hospitals, indeed, you may prefer to have a nurse going. But as I said, we prefer the nurse to call first the primary doctor on the ward. If it's a surgical ward, we need to call the surgeon who operated. We don't want the surgeon to say, oh, call the team, oh, the patient has fever, call the team, and then we run all over the place all the time. Well, we could have some information coming from the relatives, but the relatives, in my opinion, should not call the rapid response system. Reserved to the personnel. They should not touch that button because some relatives would not do it because they would be afraid to disturb the doctors who are very busy, and some others would push all the time because their parent is not doing very well. So we should first call the primary doctor, but let's recognize that the doctor may be busy indeed. If there is no organized system, I have seen it in some French units in particular. They call the ICU and they say, we need a doctor, we need a doctor. That's totally obsolete. So we need the rapid response system, but it should be really mediated by the primary doctor on the floor saying, you know, guys, I would like to have your opinion. You are my colleague, you are experts, please come. I have the greatest respect for those who develop the Muse, and the news, and these scores for nurses. I think it was very good, but it will be over soon. It will be over because this will be done automatically very soon. You know, with my colleagues, when we developed the so-called sepsis 3 criteria, people speak about definitions. It's not a definition, it's new criteria. My colleagues wanted to have a simplified SOFA. SOFA is not designed for alarms. SOFA is just a way to describe organ dysfunction. But they said, what about a quick SOFA? A quick SOFA just reminds us that increased respiratory rate is very important, like hypotension and altered mentation, very important, not only in sepsis, but in any kind of crisis. So I like the fact that we could add some blood tests. Already 9 years ago, or 10 years ago, we could see this paper where they described an alarm system for nurses including the capillary refill time. That's good. Including the lactate, including the platelet count. I think that's quite interesting, and it was shown to have a good impact on outcome. We had this roundtable conference in Brussels just before COVID, and we emphasized together that the rapid response system should really be considered as a help. Hello, we are here to give you help, advice, collaboration. Don't hesitate to call us. But we are not replacing the doctors on the floor. We have all heard about examples of doctors making rounds, and when you arrive with your team, they say, yeah, we have to follow the round, but the patient who is not well is in the next room there. Please go and check the patient. No, no. If I'm going on the floor, I would like you to go with me at the bedside, and we will discuss it together. I am here to help to adjust, perhaps increase therapy, to organize transfer to ICU, or perhaps discuss therapeutic plans. There may be end-of-life issues, very important to consider as well. And this is not only before the ICU, it's also after the ICU. That's indeed what we call ICU without borders. We go to the floor, we discuss. Now, it's not just an alarm system. It's also improved communication, better planning, teaching the others. We need to work together, and the patient is along his or her trajectory. Oh, there is no room in the ICU for all these cases. It's the other way around. If you have a good rapid response system, you will admit patients earlier in the ICU. They will be less sick. They may stay in the ICU for a shorter period of time. And so at the end, it may be really effective. You want to prove this is just one study published 10 years ago, an old study, but it makes the point that with a so-called continuous monitoring in an inpatient unit, the rate of transfer to ICU didn't change, but the total number of ICU days was reduced, and the rate of code blue events decreased. You admit earlier. So this brings me to the third element, improved monitoring systems, intelligent alarms, signal integration. Let me go back to this excellent publication from Dr. Davita and colleagues. The failure to monitor probably contributes to the risk of failure to rescue. That was in the text. So once again, in this difficult progression towards total decompensation, monitoring systems could actually take place before any rapid response systems take place. So schematically, what we could do is to make the problem clinically evident earlier than in the past, and with a higher degree of accuracy. In the past, there were many wires. Hopefully, the industry will help us to get rid of all these wires, and that will be much more comfortable for the patient on the floor. The heart rate will be monitored without any wire. And in addition to pulse oximetry, we will have better monitoring systems with acoustic monitoring, plethysmography, masks with inbuilt measurements of respiratory rate, with perhaps nasal capnometry. And you know, during the COVID crisis, we developed some newer systems, wireless sensors that you could put on the throat and monitor the type of breathing. We could have the fever, the temperature measured continuously. Oh, maybe not that accurate. Does it matter so much to know it's 38.2 versus 38.3? No. What's important is to have a continuous monitoring of temperature. So as we wrote here, the future is non-invasive, ergonomic, wireless, and wearable. That's a smart software. And of course, the technology will allow us to have easy access to blood pressure, not even with a smartphone, but with this type of systems. This system is about to come out and to be commercialized. It's a very clever monitoring of blood flow percutaneously. It could be put on the throat and have a continuing blood flow assessment. In the future, we may have the rings which are available today, but which will be much more reliable. It could be smartwatch on the floor, allowing the collection of many variables. That's the future. And, as already alluded to, if we look only at one variable, there may be an alarm fatigue. But if we integrate a number of variables, that would be much smarter. After all, it's rare that a patient has hypoxemia and fall in oxygen saturation without an increase in respiratory rate and maybe some fever and some tachycardia. So why don't we put it together? Look at this on seizures. Having an integrated monitoring could give a lot of information about the duration of seizures, the cardiovascular complications, the respiratory complications. We could even have an EEG if the patient has a real problem of seizures. So combining all this could make a lot of sense. So from there, let's go to trend analysis. Very important, with automated systems and, of course, AI. Right now, we put the same alarm limits for every single patient, a higher or lower limit. But with intelligent alarms, we could actually start from another value, which may be the usual value that the patient has. And so that will make alarms more intelligent. And we will look at the trend. When I visited the University of Virginia, they had, it was before COVID, they had this very smart approach. On the floor, where nurses arriving on the ward could see which patients are more at risk. Based on very simple vital signs, combining them, that would be a way to see that, that particular patient needs more attention. Just for the ward. It's not for a rapid response system. It's very clever. And then they applied, and we will hear more about the Hotman index. They looked at the trend, and this is the smart way to go. And the data were transferred, that's another unit I visited, were transferred to a central station. I'm just coming from Saudi Arabia. In Jeddah, I saw this beautiful center where they have information from all over the hospital coming on big screens. Wonderful. But will it be necessary, do you think, that in 10 years' time we will all have this type of room? I'm not so sure, because I think that that's the future. Human interventions will be replaced by automated process using AI. AI is very good not only at diagnosis, but especially in prediction of catastrophe. Well, is it important to define prognosis? Well, it's good, but it's not that essential, because it has limited implications, actually. If you tell me that this elderly patient with cirrhosis and with a history of chronic lung disease has a high risk of not leaving the hospital alive, I know it. I know it from basic information. Severity may be a little more helpful if it helps me to decide whether the patient should go on the ward or in the ICU. Prediction is important, provided that it can lead to prevention, to an intervention. That's the point. As a journal editor, I receive almost every day a paper saying, if we combine this and that, we have a very good prediction of mortality, a high risk of mortality. But what do I do with this information? Thank you. I tend to reject these papers because they will not help me in my practice. But if you find a system that allows me to intervene and prevent the catastrophe, then I am very interested. And it will never be possible 100% in 100% of the cases. You know, sometimes there is an acute bleeding that nobody could have really predicted. But you see the point? We are going from clinically evident to improved monitoring system. And now, with integrated signals and AI, we could identify the problem even earlier and with a higher degree of certitude, of accuracy. So AI is in charge. So this beautiful system of a general central station in the hospital may be replaced by something you don't see. But the immediate call on a smartwatch or a smartphone, and we will directly go, and perhaps people on the floor will not even have realized that the patient deteriorated. So there is a change in paradigm. When I was young, sometimes, oh no, Mr. Smith is back in the ICU. Yeah, please, in a rush. In the future, Mr. Smith will be readmitted, there is no choice, but it will be done earlier, and it will not be in a rush, it will be at the right time. So, rapid response systems. Today, people say, oh, we need a sepsis team, we need a cardiac team, we need a respiratory team, we need a pulmonary embolism team, a neuro team. Are you sure? I am not. No, I am not. And I don't think we need another cardiac arrest team, of course. But there has been a lot of interest for sepsis recently, because indeed we lose patients from sepsis when they could have been treated more adequately. It's my field of interest, so I'm not going against it. But I don't think we should focus only on this patient population. But in the US, as you know, there has been a number of systems like the TRUES to identify sepsis earlier and act earlier. It's true that sepsis can have too high mortality. It is true that care is sometimes suboptimal. Oh, I agree, we need to act on this. But as already written, let me go back again to this excellent paper. We can read here, textually, common conditions, acute respiratory failure, cardiac failure, changes in hypotension, arrhythmia, sepsis comes there. And of course, respiratory failure could be sepsis. Of course, changes in consciousness could be sepsis. But patients may get worse on the floor for a number of reasons. And we don't need to have a team for each of these reasons because we may not identify them well from the beginning. Sometimes we are not sure. We say, is it sepsis? Yes or no? Doesn't matter. The team should come. Look at this paper, published already 6 years ago from Dr. Liu and collaborators, showing that with an alert system in the hospital, mortality could be reduced globally in the institution. Or this paper, much more recent, just came out, well, now a few months ago, time passes fast, Dr. Arabi and co-workers looked at electronic sepsis screening in the hospital. And it works. Yes, it decreased mortality. But the interesting point is that the benefit was not limited to septic patients. Sepsis, non-sepsis, you can intervene earlier and help the patient. Even in trauma, AI systems can help in the triage of trauma victims to see which patient is likely to bleed significantly in the minutes to come. So, this paper just came out. It's with the deep car system. It shows that the application in a hospital may reduce the incidence of cardiac arrest and may reduce the hospital mortality. We don't speak about sepsis or non-sepsis. We speak about patients who may deteriorate. I think it's very, very important. And at the end, let me return to my slide here. Focus for improvement, better identification of early signs of deterioration, improved communication, better planning, teaching the others. We need to work on all this together as a package. AI may not be so good in making thoughtful decisions. This came out in the New York Times just less than 1 month ago, a couple of weeks ago, and I like it very much. When evidence is mixed and incomplete, AI is not very good. So when we speak about what we can do and what we should do. So it's nice to monitor patients to prevent catastrophes, but we will all die at one day or another. In the US, they may discuss the hospice concept, but in many parts of the world, including in Europe and most parts of the world, we don't have that particular label, hospice. And so we need to discuss adapted therapy, proportionality of care. And that's where the doctor and the team need to intervene. We will have an evolving role. We need to understand better AI, and we must understand that at some point, we should not intervene if the patient is about to die, regardless of what we do. So at the end, I propose you these 4 stages, but it's very arbitrary. It's just to try to make a sense of my dissertation here. But I think the hospital will change completely with the progress of technologies and the use of AI. It's already there, but it will develop very rapidly. And we will have a better interaction among the various departments in the hospital. And very importantly, monitoring systems will help us to identify the patient at risk of complications very early. And of course, this will be done with AI. We need to integrate multiple variables with trend analysis. Our human brain is not so good at integrating multiple variables. We can integrate 2, 3, maybe 4 variables, but 5 variables, oh my gosh, that's becoming too much. For AI, not a problem. 100 variables, that's okay. It can do it. So this will be done with less human intervention, more automatically and more accurately in the next future. Not in the future, it's about to come, because things progress so fast that our world will be soon very different for a better quality of care. Thank you very much.